Well, thank you for having me. Let me know if you can hear, if it's all right if I walk around from the podium. And I think the talks this morning were, I think highlighted both the challenges and the excitement. And I'm going to get a little more granular with you and talk about what I like to call the evidence gap. And we're going to bring this down to some day-to-day patient care in the clinical environment. So this is David Saket. For those of you who don't know, David is one of the founding fathers of what we call evidence-based medicine. He was from McMaster University in Canada. And back in 1990, David went around the clinical wards with a big trolley and textbooks on them and journal articles. He wanted to see every patient that he saw, he wanted to look to see if there was evidence in the literature to support what was being done in the hospital at that moment in time. This is before the internet, so he literally had this huge trolley that he pushed around with him, and he was looking. And at that time, and I think we had a quote from this morning, that he said only about 30% of the care being provided was based on sound evidence. Both either they were mismatching the evidence that was currently available, or there was just no evidence to support what was getting done. And sometimes it's okay to do things without sound evidence. You have to do things to take care of the patient in front of you, whether there's been research performed or not. Now you flash forward a little bit, and we still have this big gap between the evidence and the day-to-day clinical care. For today's conversation, when I talk about, I don't know if there's a pointer on this. Is there a pointer? Oh, got it. When I'm talking today, I'm talking about validated research that's typically published in peer-reviewed journals, specifically around the areas of treatment and diagnostics. The concepts of big data, which I think some people have alluded to today, I'm not going to talk about, and that's to do with the learning health system, where big health systems look at their own data and trends and react and respond to that. That's something that we're working on at Northwell, but it's not what I'll be talking about today. What I'm talking about is the gap between well-known, validated research and how does that evidence get into day-to-day clinical practice, and then how do we measure how well we're doing in that process and adjust ourselves. So, as we mentioned, we don't do a great job. Most health economists say conservatively 30% of U.S. healthcare is deemed unnecessary and over the top. 50% of the healthcare is not based on sound evidence, and that's a mix of unnecessary care and non-evidence-based care, and a mismatch when we have the evidence available and we have the patient in front of us, but we don't offer the latest evidence that's up to date. So we have this gap. What drives that gap? What makes the gap? Why is it something published in the New England Journal of Medicine, not done in patient care right in front of the patient sitting in front of us? Some of the issues that we see are inaccurate estimations of basic probabilities that a doctor makes when seeing a patient at that moment in time and makes choices about diagnostic testing and treatments. They misestimate probabilities. They get over-worried about certain things, even though the data would tell them otherwise. So how can we close that gap? Now, you know that we have all our literature published in online journals, and we all work off of electronic health records. So you would think that we could simply connect those two worlds, and every doctor across Ireland and the United States would be providing the most up-to-date care. So that's called clinical decision support. Just to be clear on clinical decision support, which now occurs everywhere. Right? You can be in the hospital on your iPad, you can be in the clinics on your computer, and this picture in the lower corner is a physician working in the operating room. These are opportunities for us to integrate evidence at the point of care. So it's really a computer-based process by which we can take evidence and integrate it. Seems like an easy thing to do. Just for a quick terminology, in our research that we do around decision support, we identify two forms of clinical decision support as either flat or complex. So we look at the validated research, we try to integrate it into the electronic health record, and then we measure how we're doing. We do very well as health systems in flat decision support. And what I mean by flat, these are basic things. Mr. Smith is in the clinic today, and it's fall, so he should get a flu shot. Mrs. Smith is in the clinic today. She hasn't had her annual mammogram. The computer says, get mammogram. These are what we call simple reminders, and we have drug-drug interactions, and we have a lot of other things along those lines. However, the more complicated decision support that we would nicely love to get to in the next 10 years or so, or 5 years, is where we can pull data about the patient's physical exam, their labs, their history, their demographics, and even pull data together from maybe what they did in the nursing home or what they did at home or something that they purchased. And we can get a better picture of that patient immediately right in front of us. And it offers the doctor a patient-specific issues about that patient sitting in front of you and may give you specific actions that you should take. And all of this occurs instantaneously at the point of care. Now, what are some forms of validated complex evidence? There are guidelines, there are systematic reviews, there are clinical prediction rules, there are decision analysis. These are validated forms of evidence that are very complicated that we would love to see integrated into our day-to-day process. For this, I'm going to give you a couple examples of the work that we're doing around clinical prediction rules. And I'm going to ask the folks in the room, whether you're not clinicians or not, to do a little clinical work for me so that I can see how you're thinking. Just so you know what a clinical prediction rule is, it's a decision aid that brings together the history, the physical exam, some basic lab tests. It can take all that information and give the doctor a probability that a patient has a disease sitting in front of them, an accurate probability, not a guess, a real probability, and it helps making frontline decisions. The difficulty with clinical prediction rules, and I've been doing research in this area for a long time, to get to a good clinical prediction rule, you need to do several studies. We usually derive the rule in one setting, we take that rule that we've created, we validate it in other settings, and we publish in each one of these studies. So this could take several years before we get to a good clinical prediction rule. And then at the end of the day, we try to integrate that into practice and see if we can change doctor behavior. This takes a lot of work. We, in our group, we rank these prediction rules, of which there are dozens of these tools out there. And we look at the ones that we think are the most evidence-based and sound, and then as a group, we decide to see if we can interject them into the electronic health record. The only way to really understand this is to try to do a case. So let's do a case. Okay, how many of you in the room are clinicians? Raise your hand. All right, we have only a small handful of clinicians. How many in the room know what a clot is? All right, good. I want you to hear this case and tell me the probability that you think this young lady has a pulmonary embolus, which is a clot to the lung, okay? She's a 45-year-old female, sudden onset of chest pain. Her chest pain lasts for seconds, but her shortness of breath continues. And she goes to the emergency room concerned that she may have had a blood clot. She's got no past medical history. Her saturation of her blood is 95%, which means she's oxygenating well, but her pulse rate is 98. And she has a normal chest x-ray. Now just do this for me. I know you're not doctors in the room. And I'm looking at Michael Dowling. I know he's not a doctor. I want you to, if you have a pen, I want you to write down the probability that you think this patient has a clot. I'm going to talk to my current chairman of medicine sitting in front of me. I want you to write it down. I want everybody with a pen to write it down. Did you write that down? I work with medical... Now, why do I ask to write it down? The reason I ask people to write this down, because I teach medical students, and what happens is if you ask one medical student what they think the probability is, they say a number, and then all the other students guess about 2 percentage points on either side of that. And it's usually the really smart, kind of noisy one that says, did you write down a probability? You did. Michael, did you write down one? He did. He didn't write it down, see? It's so hard to get people to write it down. Did you write it down? Patrick, where are you, Patrick? Did you write it down? No, he's not. Okay. Did everybody write it down? All right, good. All right. So patient is given a blood thinner and sent up for a CAT scan to see if they really had a clot in their lungs, which is life-threatening, can kill you. And you have to start them on that blood thinner. And if they don't have, and the blood thinner can kill you also, right? It can make you bleed in your gut. It can make you bleed in your head. So you're giving them blood thinner because they think you had the clot, but you don't know if they had a clot. Now, let's see how you all did on guessing. I just need a show of hands. How many people did the 0 to 20% range? Raise your hands. Fabulous. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. How many did 20 to 40%? Got a little bit more. I'm going to give it 16. All right. How many people did what's the next rate up? 40 to 60%. Got about 10. Okay. And then how many people did above 60%? All right. We got about 7 or 8. So think about that. Just let's do the general numbers there. We had about 14, 13, 13, 7. We're about 10%. We're spread across the whole spectrum. I've done that case at Johns Hopkins, at Harvard, Now here in Limerick, I get the same spread no matter where I go, whether it's doctors or no doctors. I am not kidding you. It is the same exact spread. So all of you who guessed, congratulations. Because you're right on target with Harvard, Hopkins, Trinity, and now Limerick. Okay, and I did this at Trinity, by the way, also. It's fascinating to me, and it takes no clinical experience to be completely wrong. All right, the CAT scan is done. Of course, radiologists will never tell you it's normal. They don't allow that. It's against the rules in radiology. What they'll tell you is it's very low probability. So, I'm trying to figure out why I'm off one slide always here. Okay, so for those of you who don't know, this is called a nomogram, okay? On my right, on your left, is what we call your probabilities that you just guessed, okay, on this side. So you could put that down here. The thing in the middle is called a likelihood ratio. Forget about that. That's the test order, the CAT scan. It takes your probability, you order your test, you end up with another probability at the end. Does that make sense to everybody? So you go from where you thought you were, you order a test, and then you go to somewhere else, okay? Okay, for those of you who are guessing in the low prob area, the CAT scan converted you from a 10% to about a 5%, okay? Didn't do you much good, did it? You were kind of low, and now you're kind of low. Those of you who guessed in the high pretest range, okay, you went from about, say, 80% to 60%. Also, not that helpful, right? Now, what we say is these are what the action thresholds are. The low probability group passed the threshold where you will discharge that patient home. It's now gotten so low likely that she's probably just a little anxious and you want to send her home. Those of you who guessed in the high probability will continue to give a very dangerous blood thinner and treat the patient at home, in the hospital. All of you are very smart. All of you did just like we did at Harvard. Same patient, same big fancy CAT scan, but you did completely different things, didn't you? Based on your assessment inside your head, what you thought the probability was. This is a very important lesson. It goes on all day long in healthcare. So, is the probability of your guess important? Well, the low probability group sent home. The high medium probability sent patient continued to get blood thinner and got more diagnostic studies. And very expensive tests, no less. So the assessment that you do every day as a doctor, whether you're in the clinics or in the hospital, is not very scientific and drives a lot of the utilization in healthcare. So we realize this. There's a thing called the Wells criteria. There's many models that can calculate the probability consistently everywhere you go, the probability that you've had a blood clot. It is published, it's on the internet, it's everywhere. But no doctors use it. I don't know why. Okay, this patient was a low probability patient, okay? She should have been sent home. She did not need the blood thinner. She did not need another diagnostic test. The evidence was sitting on the internet right in front of a computer in front of the physician, but they decided not to use it. It's a problem. So what we've tried to do is to try to take things like this rule, which is a well-validated tool. It's not used consistently. CAT scans are ordered unnecessarily. The biggest problem with a CAT scan is not the positive test. Not the true positive test. It's the false positive test. The number of false positives in patients over the age of 60 who get a CAT scan is upwards of 70%. 70% of patients over the age of 60 who get a lung CAT scan are going to have some finding, okay? So, and if you look at that, and if you try to get at waste and inappropriate use and evidence, for some reason this is not moving. This is what I call the wake of a diagnostic study. So that's a boat and that's the wake. Think of the boat as the CAT scan. And it's a false CAT scan. The patient's healthy, but it says they've got a little something on their CAT scan. Say that young lady got a CAT scan done. She's perfectly healthy. The odds of something coming up false positive are very high. Now, what happens after you order that test? The cost isn't that test. The cost is all the tests that follow her because she had a false positive. If she had a little something on a lung, maybe when she was a kid she had a pneumonia and a little fibrotic tissue, they're going to say, you need some blood work when you see your doctor. You're going to need a repeat CAT scan in 6 months and probably in a year, and you may eventually go for a biopsy on something she never needed. So we try to nip it in the bud and use these prediction models, but the problem is nobody's using them. So how do we take a Wells model and put that into an electronic health record and have it used across our entire health system? That's our challenge. So someone tried this earlier, about 5 years ago, this Drescher, 2009. He got a 20% adoption rate when he tried to push that into the electronic health record. And he gave up because he said the emergency room environment was too complicated. Nurses weren't working well with the physicians and the PAs and the nurse practitioners, and nobody was working with the tool. So we decided, of course, we were going to tackle this. Basically what you do is you have an input-guided activation. The tool is triggered when the physician puts in certain terms that we've decided would trigger the tool. And then it'll help the patient divide into 3 probabilities: intermediate, low, and high. From there, you have to look at the workflow in any of these environments if you're going to do any input or work and change behaviors. We did a basic workflow diagram of our emergency room at our tertiary medical centers. Patients come in through the ED in all different ways. They get put in different rooms. The nurses triage them. The MDs look at them different places. They get shipped out to have a CAT scan performed. So how are we going to get into this busy environment? And we think IT is the solution. It's a simple solution. Just put it into the computer. But if you don't look at the workflow and the environment, all that fancy IT work you're doing is not going to influence this complicated environment. You think, I have this thing, this evidence, and I have this computer, and I'm just going to put it in there, and everybody's going to do what it says. You walk into a workflow environment like that, you're not going to get anywhere unless you understand how that workflow is working, what the nurses are doing, what the social worker's doing, where the patient is sending to rooms. So what we do before we try to do any fancy IT fixes, we go into the workflow environment and we say, where does the nurse triage? Well, let's see. They triage in this room. We're going to give a little prompt in the computer screen down here in the lower left. Then the patient moves into another room, and we're going to follow that patient throughout the emergency room, and the calculator will be shown to another nurse in another room. And then as they walk through here, their risk stratification is going to occur. The shift changes, and a new doctor comes in. So we have to be aware of the new doctor that just walked in, and we're going to make sure that doctor sees another reminder. And we map these things out across the board. This is not about sticking something into a computer. It's about understanding workflow, culture, and all the other elements that go on in a busy environment. And all these things have to be taken into consideration for that one woman that you just guessed on the probability of disease. Otherwise, no one's going to follow what you're doing. This is just a little example of all the different prompts, reminders, and calculators that we will use in the process of evidence integration into a clinical into an electronic health record. All right. Now, this is a little schematic of our health system. These are all the hospitals that are part of the North Shore LIJ health system. This pulmonary embolus prediction model is being piloted at Long Island Jewish right now. We're just in the early phases of doing those analyses, and we've had about a 50% adoption rate of the tool, and we're going to move into North Shore actually next month when I get back, and then the next targets are throughout the entire health system. We're going to slowly push this out. We average about 150 CAT scans per patient for a positive patient for a PE, which is the average in the United States. Think about that. 150 CT angios are ordered to get one diagnosis of a pulmonary embolus. Our target is to reduce that below 100. You don't want to get too low because then you're going to miss some. But we're slowly pushing that out across the system. I'm going to give you one more quick case study. This is an ambulatory outpatient example. One of the biggest problems we have in the United States, and I think it's probably true here, is overuse of antibiotics. Something in the ambulatory setting, something about 80% of all antibiotics prescribed are unnecessary and given for viral syndromes, for sore throat, and for cough when it's just a viral syndrome and not a pneumonia. So we decided to tackle this problem. There are 2 validated prediction rules. Again, totally available. Doctors should use them, but they don't. They're in the internet. They're everywhere to be. One is called the Walsh prediction rule for strep pharyngitis. The other is called the Heckerling rule for pneumonia. So we said, let's put these into the primary care settings and figure out how we can get doctors to reduce their antibiotic prescribing. Just like in the emergency room, you don't walk into a primary care office and just say, we're going to shove this into your computer. What we did was we went to our simulation center. We took the primary care doctors into our simulation center. We had actors as patients, and we built the tool into the computer, and we modeled a primary care setting. And then we tweaked the tool, we fixed it, we looked at the workflow issues. This is what we call usability testing. And if you don't do this, this took us 3 to 6 months to figure out how to put these 2 basic rules into the computer so that we could actually have doctors change their behaviors. Again, if we didn't do the front work on the usability testing, we would just be having a nice new shiny IT intervention with no effect, okay? So after doing this for 6 months, we randomized the tools by providers. Certain doctors got the reminders and certain doctors didn't get the reminder. And so we could measure the impact of our intervention on antibiotic prescribing. This is just a quick schematic of some of the tools and how they trigger and different. This is the calculator. A great thing about this tool, by the way, it triggers, say I'm a doctor and I'm in the office or a nurse and I put in sore throat. It offers the tool and says, do you think your patient has strep pharyngitis? If you say yes, would you like the calculator? You get the calculator. Here's the probability. Would you like us to write your note? We learned the doctors are not going to do all this unless you write the note for them. And then once you get the probability, it says, would you like us to offer your patient a prescription and some support services? Click yes. Automatic prescription send. Patient education, would you like that in Spanish? Would you like that in English? Yes, we would. And all of that is done, taken care of, the note is written. Otherwise, the physicians are going to completely ignore the advice. So that's how we ended up doing it. This last piece over here is actually a list of prescribed antibiotics. If you are going to give them, these are the ones you should use. Instead of using the all-powerful Z-Pak, which everybody loves, we actually had doctors prescribe penicillin, something they haven't done in years. So what happened in all of this? The thing to look at, the first thing that we look at in the middle row here is adoption rates. 74% of the time doctors were offered the tool, they accepted it. Prior experience without doing the upfront 3 to 6 month usability work was 10%. If doctors are not going to accept the advice they're getting about evidence, they're not going to follow it. They would just click through it and ignore it. So 75% of our physicians in the strep pharyngitis rule accepted the advice they got. And what did that do to their antibiotic prescribing? It got it down. I'm sorry, I should have pulled this out for you. A 35% reduction in 4 primary care sites in urban Manhattan, in a very poor community, 35% reduction in antibiotic prescribing. And we were only just learning what to do in this case. So we are now working with several groups in Utah, in the University of Wisconsin, and Boston, and in our health system to roll this out in 80 primary care sites, and we're randomly allocating this intervention. It's funded through the NIH, and it's a 5-year study. We just finished our first year, and we're about to start rolling it out. We spent 1 year analyzing the workflow environments in each of the practices before we put it in there. One of the messages behind all this is that IT solutions are only part of a bigger solution. You have to deal with culture, environment, workflow. IT doesn't solve anything unless you deal with those things. It's only part of the solution. This slides are. So in summary, when you want to put evidence into action, you have to look, first of all, you have to look at the quality of the evidence. There's so much evidence out there that's not being utilized. We like to cherry pick the things that we think will have the biggest impact on healthcare, and it's usually getting at the problem of overuse of unnecessary technology, unnecessary antibiotics. We also look at how easily can we take that evidence and integrate it into the workflow so that it'll get adopted. There are some complicated forms of evidence and decision analysis and all different other things that we know will never easily get integrated into care. Right now, we have what we're trying to build, and we're actually working with a lot of IT startup companies, is to build a cloud-based library of evidence-based prediction tools that can integrate with different types of electronic health records. The holy grail right now in working on evidence integration is cloud-based solutions that are outside of the electronic health record but can integrate with the health record. And that way we can share it across multiple centers. We can share it out west, we can share it out east, we can share it north, we can share it south. But we're not there yet, but it's something we're working towards. So if all this is successfully done, we can bridge the evidence gap, we can reduce waste and increase quality. But it's real hard work at the ground level of how practice is performed. I'm going to stop there. I got to thank all my teamwork. It's all teamwork here. I work with a lot of different universities, Boston University, I'm funded through AHRQ, which is a branch of the NIH, University of Utah, University of Wisconsin. And actually, just to highlight, I don't know if it's a competitor, but I'm working with the Royal College in Dublin with Tom Fahey's group, and we are submitting several grants and looking at similar concepts around evidence integration in Ireland. And there are opportunities for joint funding between the NIH and Ireland that we're just submitting that now. So I just want to stop there. One more thing. I am a prediction modeler. That's what I do for a living. So I spent a lot of time thinking about this particular issue, and I had a great time. I actually sat and watched the game in a Galway pub, which was quite a treat. I know we're down about 4 players, including the captain and Sexton. But I did the prediction modeling. I put those elements into my model, and Ireland wins by 1 try. But it's going to be pretty close. The Pumas they're pretty tough, but we're going to win by about 1 try. So thank you very much.